how we assess and treat sex offenders. So let's begin by just kind of thinking about or looking at the history of treatment. So originally, offending was thought of as a result of an individual's psychopathology, and therefore most earlier treatments were medical or psychoanalytical in nature. Medical models implies that offending is like a disease, and what we want to do is to treat the underlying problem. At the start of the 20th century, Freud claimed deviant behavior was unlikely to change, and that in order for psychoanalysis to work, it would need to be fairly lengthy. So one thing that also was used as a treatment form is castration, and the idea here was that this would reduce the libido of offenders and therefore decrease offending. It doesn't appear to affect the sexuality of the adult male on a purely biological basis. Medical treatments for sex offenders surfaced in the 1940s. And they began linking sexual behavior to hormonal changes. Estrogen appeared to be fairly successful but had side effects. By the 1960s, they're using other pharmacological interventions like thyroidazine and flufenazine. They're also using CPA and MPA, and these are anti-androgens. By 1950s, we're focusing on behavioral therapy, modifying deviant fantasies, operant conditioning, aversion therapy, orgasmic reconditioning, and shaping. And they also focused on eliminating homosexual desires. In the 70s, multimodal approaches are being used, social skills and looking at cognitive distortions. In the 80s, they're looking at relapse prevention, how to recognize and manage fantasies and behaviors, increasing victim empathy, restructuring cognitive processes, refining sexual arousal monitoring, and increased validity of physiometric testing. In the 90s, they start using polygraphs for treatment, and they start looking at self-regulation and good lives models, which emphasize the positive aspect of offenders' lives and risk management. In the 60s, we have this rehabilitative ideal. Many programs were established quickly and without adequate planning and assessment, and many turned out to not be very effective. So by the 70s, we have this decline in rehabilitative ideal, and in the 80s, we start to see an increase in this again. Researchers failed to take into consideration, though, the methodological problems of studies they were evaluating. So they did find some positive results in multimodal cognitive behavioral therapy programs. In the 80s, we start to see an increase in professionalization. We see the first professional association, academic journals, and standards and guidelines for practitioners are developed. So treatment can only be effective if the full nature of sexual thoughts, feelings, and behavior of offender are known. So one thing that needs to happen is an extensive background checks. This includes documents from the criminal justice system, victim statements, past treatment, and medical records. And past criminal history is an important variable here. We want to look for discrepancies between what an offender has told us in their accounts and official records, and address any denial or minimization in treatment. When appropriate, they will measure the level of deviant sexual arousal in offenders, and this can be done through PPG or a psychophysiological hand monitor or a volumetric philometer. This tool is only effective in conjunction with other assessments, though. It's difficult to identify any deviant sexual attraction just by showing people erotic images and measuring their sexual arousal. Not all sex offenders are driven by sexual needs. In fact, many are driven by a desire for power and control. We could also use a battery of psychometric and actuarial tests. This is a battery of tests used to assess intelligence, psychopathology, personality, social attitudes, morality, respect for others, and the presence of negative emotional states. So one that gets used quite often is the MMPI. This is the Minnesota Multiphasic Personality Inventory, and the MCMI, which looks at Axis 1 and Axis 2 disorders. So the most common treatment is what's called cognitive behavioral treatment. And here's some of the things it attempts to do. It's trying to get an offender to recognize their problems and behaviors, understand feelings that lead to their deviant behavior, identify and eliminate their cognitive distortions, accept responsibility for their behavior, reevaluate their attitudes and behavior, acquire pro-social expressions of sexuality, gain a higher level of social competence, be able to identify high-risk situations, and understand the repetitive nature of their behavior and be able to break that sequence of offending. Most programs are ATSA certified, so they follow specific behavioral regimes developed by researchers. Programs should address cognitive restructuring, empathy enhancement, emotional management, and sexual arousal control. Treatment providers should reassess the purposes of and ways in which they address their cognitive distortions. So, what are some targeted areas of treatment? Well, one thing we really want to focus on is victim empathy. This could result from a lack of intimate relationships, and it may result from the sex offender's inability to attribute appropriate thoughts and feelings to others. Some programs will use role-playing, where the offender acts out the role of his victim, but there's some mixed results about whether or not this is really effective in increasing victim empathy. This doesn't necessarily increase the ability of offenders to recognize affective cues in other people. Offenders need to better understand appropriate pro-social behavior and may need treatment to recondition their arousal patterns. So they might need to learn how to recondition what sort of things arouse them. And this can be done through classical conditioning, but requires the cooperation of the offender. They also need improvement in social skills. They need to learn how to interpret situations and other people's behavior, consider possible responses to situations and how to choose the best option, and then decide whether or not the response is carried out. We should focus on strategies for controlling negative emotional states and addressing their triggers. So one thing that they might look at here is what sort of things trigger them, okay? So deviant cycle patterns are first developed for substance abuse, and I've actually seen this type of therapy work done before. And the idea here is to interrupt the succession of events, learn coping strategies, and problem-solving strategies as well. So another thing that often happens is group treatment. Most cognitive behavioral programs are conducted through group processes because peer confrontation is a good way to overcome cognitive distortions. It's also very cost effective, and it is found to be most helpful for sex offenders who admit to their offenses. There's multiple approaches to group therapy. A confrontational approach is where people aggressively challenge offenders, and responsibility for change is put on the treatment providers. This, however, may make offenders very defensive. Whereas a motivational approach leaves responsibility for change with the offender. And the treatment provider creates cognitive dissonance, psychological discomfort, that acts as a motivator for change. And this is best used when working with deniers. Medical treatment, this can often be done as pharmacological treatment, the goal being to reduce the sexual drive of offenders. So CPA is an anti-androgen and an anti-gonadotropin. Doesn't seem to have any effect on sexual fantasy or erectile responses outside of experimental situations, and it doesn't necessarily reduce sexual aggression. It does, however, come with some side effects like depression, breast enlargement, increased weight, and osteoporosis. This is limited and occurs after years of use, but basically what is done is male sexual offenders are given female birth control. They're given Depo-Provera. MPA is the most commonly used hormonal agent. As I mentioned, it's Depo-Provera and is considered temporary chemical castration. There are some ethical considerations here, but we can document compliance. Pharmacological treatment is generally offered to paraphiliacs, especially pedophiles, but the use of these treatments is limited without any additional psych treatment. It can be difficult to administer this to inmates, and informed consent is also required, even though the law doesn't necessarily make that consent entirely voluntary. Physical castration is pretty rare today, and it obviously dramatically reduces the amount of testosterone that's circulating, but the effects are not complete, and there are obvious ethical issues here. Sexual arousability and functioning are also not the only contributors to offendings. So California has mandated chemical castration for two-time offenders. They've made it optional, and this allows the offender to remain in the community. Okay, what about community treatment versus treatment in prison? Community sentences are usually mandated treatment, and most correctional programs have treatment, but it is not sex offender specific. Treatment works best in the community. Inmates are not subject to environmental triggers that are present in the community, and so it makes it really difficult for treatment providers to help offenders work with that. Institutional treatment rarely follows up with offenders long term. There's little communication amongst agencies about what type of treatment has actually occurred. Okay, so let's think about some ethical issues here. So some argue that providers breach ethical principles by putting the interests of the community ahead of the well-being of the offenders, whereas others argue you can balance both. But one big concern here is whether or not treatment is truly voluntary. If I offer you a lesser sentence or the ability to remain in the community versus in prison, is that really a choice? Voluntariness then is more of a matter of degree. We also want to think about whether or not coerced treatment is effective, but studies do show voluntary treatment is more effective. Also, recall in the beginning of this chapter, they talk about how in order to be effective, we have to know everything that's going on with the offender. But full disclosure by an offender may result in further punishment. Treatment is also only effective when delivered by adequately trained staff. These staff need to be direct, open, truthful, and consistent. They cannot be uncomfortable around sex offenders or dealing with their issues, and they need to be aware if they're developing countertransference. This is emotional responses that they would have in relation to the offenders. This is highly intensive and emotional work. Most programs have admission criteria, and offenders who do not meet them will not be accepted. So denial of offense could be a cognitive distortion, psychopathy, low intelligence, or if they score high on the psychopathy checklist. So how do we know if treatment is effective? And that's the biggest question here. Is it effective for whom, what types, and in what situations? Various meta-analyses indicate there are positive outcomes overall for sex offenders who complete treatment. We also want to think about how we're going about researching this methodologically. So if in terms of the dependent variable, we want to think about what is being measured. And many evaluations are using official data. And even then, the definition of a recidivist varies. We also want to keep in mind that sex offenders as a sample are a heterogeneous group. And treatment groups often have exclusion criteria. So composition of a treatment group will affect the outcome of the program. Follow-up periods also vary, anywhere from, in about a quarter of recidivists were reconvicted 10 years later. So we would like to see a longer follow-up period here. We also want to think about the type and location of a treatment because those also affect outcomes. We also want to think about type of design. Do we need an equivalent matching group or control group? We obviously can't use random assignment here. That would be unethical. We also want to make sure that the person evaluating the program is objective, so they shouldn't be directly involved with the program. So the meta-analysis of 43 studies found lower recidivism rates in treated sex offenders for both sex offenses and general offenses, with their sexual recidivism ranging from 10% versus 17%. Other studies have looked at outcomes based on types or characteristics of offenders. The least likely to recidivate were intrafamilial child sexual abuse, older offenders, and offenders with no past offenses, so essentially first-time offenders. Offenders who drop out of treatment are at an equal or higher risk to reoffend than those who do not participate at all. For some offenders, high sexual arousal plays a role in offending. Use of polygraphs appears to have some effect on recidivism, and untreated sex offenders reoffend more quickly than those who have undergone treatment. And that wraps up this chapter.